Moving on to skeletal muscle, the first disorder that we're going to discuss is dermatomyositis. Now the name here tells you a lot. You've got myositis, which is inflammation of the muscle, and dermato, which implies that you have inflammation of the skin. And so this is going to be an inflammatory disorder of both the skin and the skeletal muscle. The etiology is not known, but what is particularly high yield is that some cases of dermatomyositis are associated with carcinoma, for example, gastric carcinoma. Board examiners like you to know that if a patient presents with dermatomyositis, you need to consider the possibility of an underlying carcinoma, especially in the stomach. The clinical features of dermatomyositis are that you'll get bilateral proximal muscle weakness, that's high yield, and by proximal muscle weakness, the way by which the patients would present would classically be they will say that they can't comb their hair, because when you raise your arm to comb your hair, you need to use the shoulders, and they can't climb the stairs. Now, late in the disease, they can develop distal involvement, but again, the hallmark is proximal muscle weakness. In addition, we would expect to see skin changes, and there are 3 key skin changes that you look for. Number 1 is a rash of the upper eyelids, and this gives a little bit of a purple discoloration to the upper eyelids. Number 2, a malar rash, and I think that this is particularly high yield because board examiners like to go after this. And the reason they like to go after it is because you classically associate a malar rash with lupus, but you need to remember that you can also have a malar rash in dermatomyositis, and that again is particularly high yield because it's one of those knee jerks that, once you see the word malar rash, you think you're done and you pick lupus. However, actually you were dealing with dermatomyositis. And the third rash would be these red papules on the elbow, knuckles, and knees, which are also known as Groton lesions. And again, you're going to have muscle weakness plus some skin finding. On laboratory exam, the patients will have an increased creatinine kinase. Creatinine kinase is an enzyme present in muscle, so when muscle is damaged, this will leak out into the blood. You'll have a positive ANA with an anti-Jo1 antibody. Jo1 antibody is very important. It's the hallmark of this disease. Be careful about the positive ANA. If they tell you on the board exam that there's a positive ANA and a malar rash, don't go after lupus until you also have a confirmatory test like a double-stranded DNA antibody. Or, if you have an anti-Jo1 antibody, then think about dermatomyositis. The hallmark and one of the defining features of this disease is that you have perimesial inflammation with perifascicular atrophy. Now, in order to understand that, let's go back and remind ourselves, this is the muscle fascicle, and the fascicle is made up of a bunch of individual fibers. Now, the connective tissue that sits out here at the edge of the fascicle, this is called the perimesium. And the connective tissue that sits in between the fibers, this is called the endomesium. Now what happens in dermatomyositis is that you get inflammation at the perimesium, so out at the edge of the muscle fascicle, which then results in perifascicular atrophy, or atrophy of the muscle with inflammation out at the edge. This is very high yield because it helps to distinguish dermatomyositis from another entity that we're going to talk about, which is polymyositis, because in polymyositis you're going to have endomesial inflammation. And the way I remember this, i.e. that is it endomesial or perimesial, is that the perimesium is out at the edge and so it's closer to the skin. And so in dermatomyositis you're going to have perimesial inflammation, which is closer to the skin, and so therefore it sort of matches with the concept of dermatomyositis. Now again, that's just one way to remember it, but I think it's helpful. Here's an image to highlight the same principle. This is a muscle fascicle, and you'll notice that you've got inflammation out in the connective tissue at the edge of the muscle fascicle, resulting in some atrophy of the muscle cells. Now notice that this is the normal size of the muscle cell, and can you notice that these here are smaller, hence they become atrophic. And so again, perimesial inflammation with perifascicular atrophy of the muscle. And so the way by which I remember this is, let's assume the skin is way out here, way above in this section, then this would be sort of closer to the skin, and that's how I remember that as part of dermatomyositis. One final point concerning dermatomyositis, and that is that the treatment is corticosteroids. Of course, this is an inflammatory disorder, and corticosteroids would limit the inflammation. Polymyositis is an inflammatory disorder of skeletal muscle. It resembles dermatomyositis, especially with the proximal muscle weakness. However, the skin will not be involved. So you will not see malar rash, you will not see a purplish rash of the upper eyelids, and you will not see Groton's lesions on the knees and the elbows, for example. In addition, one key distinction is that in polymyositis you get endomysial inflammation with necrotic muscle fibers. Again, this endomysial is particularly high yield, so here you've got the muscle fascicle made up of a bunch of fibers, as I've already illustrated. This was the perimysium, this is the endomysium, and so what's going to happen in polymyositis is that you'll have inflammation scattered throughout this muscle fascicle between all of the fibers. Again, you'll have endomysial inflammation. Moving on to X-linked muscular dystrophy, this is a degenerative disorder characterized by muscle wasting, but the most important and most high-yield point concerning this disorder is that you get replacement of skeletal muscle by adipose tissue. In fact, that's really what's meant by dystrophy. And so X-linked muscular dystrophy, replacement of skeletal muscle by adipose tissue. Now, it's high yield to know that this is due to deletions of dystrophin, and there's a few points that I'd like to make clear, all of which show up on exams. Number one, it is due to deletions of dystrophin. This is also known as Duchenne's muscular dystrophy, and remember that Duchenne's is also due to deletions, and so they both begin with a D. The second point that you have to know is that mutations are often spontaneous in this gene. Now, the reason this happens is because this gene is the largest gene in the human genome. And so therefore, because of its large size, there's an increased risk for spontaneous mutations. And the third point is that dystrophin is an anchor molecule that anchors the muscle cytoskeleton to the extracellular matrix. Now imagine if this is a muscle cell and you've got all of your filaments in it, then dystrophin is sort of this linker molecule that allows you to then interact with the extracellular matrix. It's one of many proteins that do so, but it is an essential protein, again, that links the muscle cytoskeleton to the extracellular matrix. Patients with Duchenne's X-linked muscular dystrophy, they present with proximal muscle weakness classically at 1 year of age. So the disease begins proximally, for example, in the thigh and the hip, and then eventually progresses to involve the distal muscle. Now the hallmark of this sequence is calf pseudohypertrophy. Let me just explain this. So at about 1 year of age, the child is learning how to walk. Now when the child is learning how to walk, at the same time, the proximal muscles are going to start becoming weak. When the proximal muscles become weak, the child is then going to put more force on the calf muscle in order to walk. And as they put more force on the calf muscle is going to undergo hypertrophy. Now over time, the disease will progress and then come distally. And as it comes distally, it's going to hit the calf, and when it hits the hypertrophied calf, it's going to convert the calf from muscle into fat, because that's the hallmark of muscular dystrophy. And so then it'll look like the calf muscle is big. However, were you to put your hand on it, it would actually be full of fat. So that's why they call it pseudohypertrophy. The calf does look big, however, it's just really full of fat instead of muscle. In addition, the creatinine kinase will be elevated, and again, the reason that the creatinine kinase is elevated is that you have damage to muscle cells, and creatinine kinase is an enzyme present within muscle cells. Death in this disorder results from cardiac or respiratory failure. Eventually, the myocardium or the diaphragm will become involved, resulting in cardiac or respiratory failure. And again, the myocardium is commonly involved. Becker muscular dystrophy is the exact same disease as Duchenne X-linked muscular dystrophy. However, remember that in Duchenne's you had a deletion of dystrophin, whereas in Becker's you have a mutation of dystrophin. Now this mutation allows for some of the protein to be produced, and so therefore you get clinically milder disease. So it's very similar, however the patients have clinically milder disease, and again the hallmark would be focal replacement of skeletal muscle with fat and also muscular weakness. Moving on to the neuromuscular junction, there's two disorders we want to cover. However, before we do that, we need a little bit of background. So let's remind ourselves that the neuromuscular junction has a nerve. It contains acetylcholine, and it has a calcium channel here that, when open, allows for the release of acetylcholine. There is also a muscle plate with acetylcholine receptors, and it's these receptors that bind acetylcholine and then cause firing of the muscle. Now the first disorder is myasthenia gravis, and in this disorder you have an antibody against these receptors. The antibody does not destroy the receptors, it merely competes with acetylcholine at the level of the receptor. So what's going to happen is the first time you have firing of the nerve and you release acetylcholine, let's imagine that 50 molecules of acetylcholine are released. They'll compete with the antibody, kick off the antibody, and allow for a proper contraction of the muscle. However, with rapid contraction of the muscle, you'll have rapid firing of the nerve, and you'll only be able to release, for example, the next time 40 molecules, and then, for example, the next time 30 molecules of acetylcholine, etc., until you get to the point where you're releasing fewer molecules of acetylcholine with each contraction. Now, as that occurs, and for example, you're only releasing 10, that's going to decrease the ability of acetylcholine to compete with the antibody, and so over time, with repeated contractions, you actually get muscle weakness. Then if there's rest, you build up additional acetylcholine, again, then you contract the muscle, and then you release 50 again, which can easily compete with these antibodies. So this is the hallmark of myasthenia gravis. Now, another important point here is that when you give the patient anticholinesterase agents, the symptoms improve. The idea is that the anticholinesterase agents allow the acetylcholine that's coming from the nerve to last for a longer time, and if it lasts for a longer time, it'll better be able to compete against these antibodies, and therefore it'll improve the symptoms. So with that background in mind, let's move on to myasthenia gravis. So as your text states, this is an autoantibody against the postsynaptic acetylcholine receptor at the neuromuscular junction, more commonly seen in women. Of course, it's an autoimmune disease. Clinically, the features will be muscle weakness that worsens with use. Again, you're releasing less and less acetylcholine as you rapidly use the muscle, and it improves with rest. And that's because if you give the neuromuscular junction time to rest, additional acetylcholine will build up within that nerve. Classically involves the eyes, leading to ptosis and double vision, and that's an important hallmark that would show up in a clinical vignette. The symptoms will improve with anticholinesterase agents. Again, the longer acetylcholine is present in the neuromuscular junction, the better it will compete with those antibodies. And very high yield, it's associated with thymic hyperplasia or thymoma. This shows up on the board exams often. And this is important because if there's thymic hyperplasia or thymoma, and you remove the thymus, the patient's symptoms will improve. And so again, this is particularly high yield, that the patients can have thymic hyperplasia or thymoma. Eaton-Lambert syndrome is when you have an antibody against the presynaptic calcium channels at the neuromuscular junction. Now recall that if this was the nerve and this was the plate here, there was a calcium channel here that when open resulted in the release of acetylcholine. So imagine if you have an antibody against the calcium channel, you're not going to be able to release acetylcholine, and so you're going to get muscle weakness. Now this is classically seen as a paraneoplastic syndrome, most commonly due to small cell carcinoma. Again, you'll get impaired release of acetylcholine, and that'll then result in muscle weakness. Now very high yield to note in this disorder that the proximal muscles are involved, and the eyes are usually spared. In addition, the anticholinesterase agents will not improve the symptoms. And of course, because if you're not able to release acetylcholine, then you're not going to be able to improve the symptoms with anticholinesterase agents. And so we say that in Lambert-Eaton syndrome, you have antibodies against the presynaptic calcium channels at the neuromuscular junction. It's a paraneoplastic syndrome related to small cell carcinoma, and it impairs release of acetylcholine. The proximal muscles will be weak, and the weakness will improve with use. Let me just quickly explain this. The reason why the weakness improves with use is that you've got an antibody here competing with the calcium channel. And so what's going to happen is the more you fire this nerve, the more there's going to be a gradient trying to force calcium in. And so again, the more you use the nerve, the more the pressure to force calcium in, and you'll be able to then kick off this receptor. And so the muscle weakness will actually improve with use. And the eyes are usually spared, particularly high yield. Again, anticholinesterase agents don't improve the symptoms, and if you remove the tumor, the paraneoplastic syndrome will disappear. The final section in this chapter is soft tissue tumors. This is going to be a very brief overview of just a couple tumors. The first is lipoma. Lipo means fat, and oma means mass, so this is a benign tumor of adipose tissue. Important to know, it's the most common benign soft tissue tumor in adults. Liposarcoma, lipo means fat, and sarcoma means malignant mesenchymal tumor. So this is a malignant tumor of adipose tissue. Important to know, it's the most common malignant soft tissue tumor in adults. Also, the board examiners like you to know that the lipoblast is the characteristic cell. So if they tell you that there's a mass and the pathology report says that lipoblasts are present, you're thinking about liposarcoma. Rhabdomyosarcoma, rhabdomyo means skeletal muscle, and oma refers to mass. And so this is a benign tumor of skeletal muscle. You can also have a cardiac rhabdomyoma, and very high yield to recall, and we talked about this in the cardiac lectures, that this is associated with tuberous sclerosis. Rhabdomyosarcoma, again rhabdomyo, skeletal muscle, and sarcoma, malignant mesenchymal tumor. So this is a malignant tumor of skeletal muscle. Important to know, it's the most common malignant soft tissue tumor in children. Most common malignant soft tissue tumor in children. The characteristic cell is called a rhabdomyoblast. Board examiners like you to know that this cell is Desmond positive. The most common site is the head and neck. However, in a young girl, especially around the age of 5, the vagina is a classic site. And remember, we talked about a disorder in the gynae lectures called sarcoma botrytis, which I told you at that point was also an embryonal rhabdomyosarcoma. This was the young girl with a grape-like mass protruding from the vagina. And I told you that characteristic on biopsy, you would see rhabdomyoblast with striations within the cells, and then cells that were Desmond positive as well. And so this is what I'm referring to when I say that the vagina is a classic site in young girls, and that's probably the highest yield rhabdomyosarcoma that would show up on a board exam. And that concludes both the section and the chapter.